we are really pleased to be talking about a topic of deprescribing that is challenging. If you are at all like me, that is challenging for many of us. I come from a bit of a personal perspective as well, since my father suffered from dementia, and I had to go through the painful but ultimately very rewarding process of accompanying him through his journey of dementia. So dementia and dementia drugs can be very emotional for families. And we are really pleased to have an excellent speaker today who will help us with that. Just to let you know, just to give you what we all know, why we're doing all this, ultimately, the D2D initiative is here to reduce inappropriate medication, and we are hoping for we have that goal for a 25% reduction of scheduled medications in long-stay patients. But more importantly, we here provide you, all of you, with necessary tools, support, and the community to implement deprescribing into clinical practice at your homes and facilities. So before we get into the important topic of deprescribing dementia medications, I would like to remind everybody about the Spearhead group. The Spearhead group you can join that, and we encourage you to join it if you have made progress and really want to share with us what you have done and give us new energy and ideas. And here is an email we received from Dr. Cheryl Hawkins, Medical Director of the Evangelical Homes of Michigan. And she shared with us a success strategy that I hadn't thought about, and I really love it. They help family education sessions. Good move. Haven't done that yet. So if you haven't done it, think about that. But in addition, they use care conferences as a time to review patients and families' meds that they would like to reduce and why. And a week ahead of time, the provider is given a list of the upcoming care conferences, and then she will write down meds that they should suggest to decrease and why, and which is then discussed during the care conference. And the ADON is also part of the D2D. I think that is fantastic. I really appreciated this email, and it gave me a whole new way of approaching this. Moving right along now, I would like to introduce Dr. Leah Watson, who is going to talk to us about optimizing the use of dementia medication. We are so pleased to have Dr. Watson with us. She is a board-certified adult and geriatric psychiatrist with a passion for creating a culture of appropriate psychotropic prescribing in the long-term care setting. And here's what I like. She says she prioritizes common sense, love that, avoiding harms, and keeping the patient's and family's goals of care at the heart of all her endeavors. She's a published author. I could talk about her for a long time, but suffice it to say that she's also a published author, speaker, and recipient of numerous awards for research and teaching. She is also the co-chair of AMDA's Behavioral Health Committee that was established in 2020 to educate all of us and promote best practices in the treatment of mental illness in long-term care. So hi, Dr. Watson, and thank you for joining us today.
Of course, I am thrilled. Driving to Deprescribe is my life's work. So I am so happy that I got invited.
Oh, great. So let's start this as we like. Let's start it out with a little poll question. Just to see, there's no right or wrong answer. I just want to see where everyone is at. So which statement reflects your clinical practice on dementia drugs? Select all that apply. When I admit a patient to my facility, I usually discontinue cholinesterase inhibitors, depending on the individual patient. When I admit patients, I usually continue cholinesterase inhibitors, depending on the individual patients. And lastly, I have barriers to deprescribing cholinesterase inhibitors in my population. So would you please choose one or two of or all that apply of these answers and give Dr. Watson and all of us a little bit of a feeling where everybody stands with deprescribing cholinesterase inhibitors. And while you are doing that, I want to remind everyone that our chat is open. So at all times, if you have a question or a comment, Dr. Nazia and Michael Cinque are standing by to look at your questions, answer them, or put them forth for further discussion. So few people, what we see here, few people will, a quarter of you will discontinue cholinesterase inhibitors, but the majority will not discontinue upon facility admission, 61%, and a sizable minority have barriers. So with that in mind, we're really looking forward to Dr. Watson's presentation. We're going to start out with our case. So when we listen to her, we can think about our case, and we'll get back to it in the end. And again, this is Mrs. Smith, and she is our 88-year-old former school teacher who came to us with a hip fracture. Prior to that, she was multimorbid, barely functioning at home, and suffered from dementia, a multitude of cardiovascular illnesses, as well as depression and anxiety. We've already deprescribed quite a few of her medications, but she continues at this point on donepezil. So the question here is now for us, continue to prescribe or deprescribe. Dr. Watson, I'm going to give it over to you now.
Great. So thanks so much again for inviting me. And the poll results, actually, just to speak to that quickly, really represent not just the common issues for cholinesterase inhibitors, but what happens to all of us when we receive patients. So we're rarely in the position to be starting medications right when somebody comes to us, but we are often put in the position of having to know whether we want to continue or stop them. And really the safe bet is often to leave them where they are until somebody settles in. And I think that we know the risk of that, of course, is that then we may forget to decrease or to stop them. So it's always good practice to look at the med list when people come into your facility for your first evaluation, and really think about what, maybe I won't get rid of it today, but make your top 10 list of the medications that you might want to get rid of. And in cholinesterase inhibitors, I'll just give you the punchline, are always on the top of my list for that. So before we get going on cholinesterase inhibitors and Memantine, I just want to say briefly something about aducanumab. I'm sure everybody's wondering about it. If you haven't seen the AMDA position paper that we wrote, I have a link to it here. Feel free to read it. I'm not going to spend any more time on this. CMS is now taking under consideration the coverage with evidence development pathway to talk about payment for this, but the bottom line is we don't feel like this medication met safety and efficacy standards. It wasn't tested in a nursing home population, and it had very high risk. So I'll just say that I will not be using it anytime soon, and I'm looking forward to more clinical trial data in a representative population that really reflects the people that we take care of. So next slide, please, Sabina. So here are the medications that we currently have that I consider to be dementia medications or anti-dementia medications, AKA cognitive enhancers, which I think is a bit of a disservice. I wish that they actually were cognitive enhancers. It would be better. So donepezil, also known as Aricept, comes in both a 5 and 10 milligram form. We have rivastigmine, also known as Exelon, and galantamine, which is used far less often because it has a more concerning side effect profile. And then in a separate category, not a cholinesterase inhibitor, we have Memantine or Namenda. So just as a reminder, you guys know all this already, but just to see it out front, what the medications are that we're actually talking about. Next slide, please. So, the main point that I make in all the talks I give about medications in nursing homes is really context is everything. So when someone says the patient has dementia and they're on Aricept, I want to know what type of dementia do they have? Do they really have dementia? So diagnostic clarification, or was it a TBI? It could be any number of things for which dementia gets placed on as a label. At what point are they in their dementia process? Is this early, middle, late? Who actually started the cholinesterase inhibitors? Have they been on for 10 years and people are scared to death to stop them? Or did some well-meaning hospitalist just put it on because they saw dementia on the chart in the hospital on the way here, and they've only been on it for 2 days? That, for the record, would be the one that I would actually stop. And of course, that's assuming we get our records on time. Did they ever have a response to the cholinesterase inhibitors? I'm pretty jaded around the efficacy of these meds, but I will tell you, in my career, I have seen a couple of people that really have responded well to them, and you don't want to be the one to stop that progress. So really important to know that. Are they having side effects? We'll talk about the common side effects very soon. And a really important question is, how invested is the family? As Sabina said so eloquently, as a caregiver and a family member of someone living with dementia, it really is a symbolic medication. It's the only medication we have. We don't have any others. And it really does hold a place for people about giving up or not giving up or trying everything. And so I think it's really important to remember that as we go along this talk. Next slide, please. Just want to say, I'm happy to report that the AGS Choosing Wisely campaign is very aligned with us on this, and they believe that cholinesterase inhibitors are very prime for deprescribing. It's important when a lot of stakeholders feel the same way about things, and I think this is a very common and easy target for deprescribing, and I'm so glad we're talking about it in that way. Next slide. So how well do these medications work? That was a Freudian slip. Work. So I've always been I always chuckle when I read the data, all the systematic reviews and the metadata about cholinesterase inhibitors always start with a line like this: you get worse less fast. Well, when you have to start by saying that you get worse less fast, that's probably not a robust effect. So I always draw a line for my patients in the trajectory coming down for people that progress at their dementia. And basically what happens with cholinesterase inhibitors is you pull that line over just a touch for about 2 months, and then they go down anyway. So you get worse less fast. We know that there is no modification of disease. We do not have any disease modifying agents on the market currently. And as has been criticized many times in this literature, statistically significant endpoints do not mean clinically meaningful changes. So some of the original data showed a change in the MMSE of roughly, I think it was 1.4 or 1.6, I can't remember, don't hold me to it, which we know does not typically meet the criteria for a meaningful clinically important difference, the MCID, if you've never heard that term. So may hit a signal on the p-value, but rarely has it hit the signal on anything that's clinically meaningful for people. And it's pretty clear from all the work that has been done now that once people have a progression of their disease, the data suggests that there is no longer any efficacy of these agents at all. So more functional decline, less memory, etc. Next slide, please. This is a study that I've referred to often, and just showing one bit of meta evidence about how these drugs work. The AD 2000 study, which is old now, but I think it still stands, and it's also one of the non-industry sponsored trials, so with a little less bias, looking at cholinesterase inhibitors versus placebo. And it really found no significant benefit of donepezil compared with placebo to the two endpoints that we actually care about. So entry into institutional care, so a move to the nursing home, or progression of disability. And this is where the argument emerged that truly when people have to live in a nursing home, we really have exceeded the potential benefit of the cholinesterase inhibitor or anti-dementia medication by definition, because they can't take care of themselves anymore. If they're entering the nursing home for another reason, COPD or heart failure, and have a mild cognitive impairment, that may be another consideration. But typically speaking, people with dementia that progress enough to live in a nursing home clearly have exceeded any potential benefit for cholinesterase inhibitors. Next slide, please. So here's the side effects of cholinesterase inhibitors. It reads like a who's who list of the things we get called about every single day in our work. So cholinesterase inhibitors cause all the things that we worry about all the time with our patients, largely GI problems, which we have a high prevalence of in the nursing home setting: nausea, diarrhea, headache, insomnia. Insomnia is something that people don't talk about enough. I see it all the time. And when I stop cholinesterase inhibitors, people sleep better. People don't think about that enough. Weight loss, pain, dizziness, fatigue can actually cause depression. And these are common. These are, in 5% or more of people that take these drugs, this list. So as we know too, from addressing all of these symptoms every day in our work, when you start addressing one thing, it leads to a prescribing cascade. So as we talked about before, diarrhea then leads, of course, to an antidiarrheal that then leads to other things. And so we begin that cascade. Insomnia, of course, leads to the use of sleeping pills, which are also on the D2D top 10 prime time list of medications we don't want to use unless we absolutely have to. So it's easy to see how this happens. And when people ask me, oh, what's the big deal about stopping it? They're doing fine. I pull this list out and show how common these side effects are and what a driver they are of prescribing cascades.
But if I may interject, if we look at
please.
the patient, I mean, she is on medications for insomnia, for depression, anxiety, she has weight loss, she has pain. It is
exactly.
Who's to know what it is from, but it is certainly in the differential that the donepezil may at least be in part a contributor to some of these problems.
Right. And then, I'll point you to, I think she has vascular disease too, and serious cardiac effects are also not uncommon. I see people on beta blockers that get put on cholinesterase inhibitors that then have an acute exacerbation of a heart block syndrome. So anybody with any primary dysrhythmias, really, in my mind, it's almost a contraindication to being on a cholinesterase inhibitor because the relative benefit is so small for cholinesterase inhibitor success. And if somebody already has an arrhythmia and are treated for it, the risk of a serious side effect with a cholinesterase inhibitor is high. But I don't know about you guys, but I don't hear people talk about that very much at all. So can also have seizures. Seizures are so common in our population. We want to get rid of everything we possibly can that can cause seizures, like tramadol, for instance. A talk for another time maybe is a high risk for seizures. Lots of drugs increase the risk for seizures, and this is one of them. And of course, GI bleeding, which is just a further sequelae of all of the GI side effects. Next slide, please. So other common drug interactions, of course, any anticholinergic medication is going to work completely antagonistically against a procholinergic agent. So the whole point of cholinesterase inhibitors is to keep that synapse alive. And when we block it with an anticholinergic agent, we're basically opposing it. The number one offender, of course, are bladder meds. So oxybutynin, Detrol, and all of the cousins of those bladder medications are very anticholinergic. And it really makes no sense whatsoever to be on both of these medications at the same time. Another talk for another deprescribing day would be why we use oxybutynin anyway, because it rarely works, especially for the incontinence that's associated with dementia, which is more of a cognitive disconnect about getting to the bathroom and is typically not helped by oxybutynin. I'll get off my soapbox on that, but enough to say that one of those has got to go if they're on both of them. Other drugs, I think I mentioned this before, that cause bradycardia, such as beta blockers and calcium channel blockers, clearly need to be looked at with caution when you're continuing cholinesterase inhibitors because of the QT prolongation. And of course, our biggest fear is that it might trigger a Torsades event. Next slide, please. I think we went too fast there, Sabina. One more. Go back one. There we go. There has been, perfect, right there. There has been recent interest because I think largely because the drug makers want us to use the medications for other things to suggest that these medications actually help with behaviors. So BPSD, behavioral and psychological symptoms of dementia. I hear the argument all the time now from some of my peers and providers who want to keep these meds. Well, we can't stop it because their behaviors will come back. There's actually very little, if any, data to suggest that that's true. The data they're referring to is actually quite modest, and it's for people that were already taking donepezil, and when they stopped it compared to placebo, people that were on it had statistically significant signals showing that they had less BPSD than placebo, but there was no clinically relevant outcomes. So again, basically saying if you take them off of it, they just might get worse. It's the same sort of theory that really fuels the overprescribing of these medications anyway. There is absolutely zero evidence, unless someone has something new for me today, that shows that actually starting a dementia medication can help with BPSD. And yet I get questions about this on a weekly basis. Shouldn't we start some Namenda, or shouldn't we start some Aricept for someone with behaviors? Absolutely no evidence whatsoever for that. So when people develop behaviors with dementia, it is by definition a progression of their disease, or it represents another unmet need that's not being taken care of. It is usually a reason to stop the medication, not to continue it, and certainly never to start it. So next slide, please. So let's switch gears to Memantine. Memantine is not a cholinesterase inhibitor. It's actually an NMDA receptor antagonist, and it's really thought to be quite distinct and thought to be neuroprotective. And that was the great excitement about it when it was first marketed. The good news about it, as it's actually very well tolerated for the most part, similar to placebo in most of its adverse event reporting, which is good. It is renally excreted, so we have to take a little more care with the kidneys on this one. And the most common adverse reactions were actually dizziness, and I see this a fair amount with Memantine. Dizziness, headache, confusion, and some edema. Many of you have probably seen the edema that can be caused by Memantine. Next slide, please. So in a 2008 systematic review, it showed that Memantine might improve cognition and the global assessment of dementia, but had very small effects that were rendered not to be of clear clinical significance, which is sort of the narrative of all of these medications. So improvement in quality of life in other domains was inferred or suggested, but had no actual proof. And this was only, of course, in the case of severe Alzheimer's dementia. Of note, Memantine and donepezil are no better than donepezil alone, if you look at the data for that too. So it's one or the other. And for people that are very attached to these medications, as the symbolism, as we talked about treating their loved one with this, if for some reason they have bad side effects with donepezil, I'm very open to letting them try Memantine to see if they benefit from it in any way, and to keeping it on for a quarter or two to see how they do with it. But I rarely, if ever, will keep both on at the same time, but use them one or the other in a sequential way. I should say too, you can go ahead, Sabina, but I forgot to say that the data on Aricept really showed that 10 milligrams is not much better than 5. I don't know if any of you have heard these data, but a lot of people have a linear effect of side effects with Aricept. And so just know that if you come back from 10 to 5 in the data for the original efficacy data, it's just about as effective as 10. And so if you're going to leave somebody in 5, don't feel like you're not doing a good job. It typically works just as well if you do decide to leave it on. So deprescribing in general is thought to be sort of a shared decision-making phenomenon, as all medical decisions should be. So it's really important to engage with a family here and determine their values and preferences and their goals of care for their loved one living with dementia. It's obviously really important to do this regardless of whether they're on a medication or not, but it really offers a good jumping off point to have these conversations and to discuss the risks and benefits of continuing versus stopping. So, and having discussions about goals of care, which should occur on a regular basis, but absolutely should occur once there is a progression of illness, is a really great time to explain what dementia looks like over time and to provide anticipatory guidance about dementia in general and the futility of medications as the disease continues to get worse. Next slide. So the way I go about this is to stop one medication at a time. And I'm going to be referring to the Australian model for deprescribing that each of you may have seen. And it's going to be on a future slide here, but they have a very good algorithm that talks about stopping, how to stop these that you can refer to, but it doesn't say exactly doing it one at a time. So if people come in on both medications, obviously really important never to stop two things at once. Even if it's probably safe, it's actually probably very safe. It makes people crazy because then they try to point fingers about which one was which, and Dr. Watson ruined my day again, and there she goes stopping all these things at once. So always one at a time, and because of the side effect profile, I always choose the cholinesterase inhibitor first because they tend to be the most problematic with side effects. As I mentioned, Memantine is relatively well tolerated. So half the dose every 4 weeks. So if they're on 10, go down to 5. Leave it on for at least a month. You're never wrong going slowly unless there's significant side effects involved, and it builds confidence and trust with your partners about how you're going about the process. So slow is always good unless you're having bad side effects. And you really want to educate the family and the staff. And I don't know how many of you have seen this. I've seen it so much. There is often a brief worsening of cognition. So people are already demented, but they just look a little fuzzy when they come off of this, sometimes for a few days. But in my experience, almost routinely within the next week or two, they actually have a clarity about them that they had not had before. So I think of these meds as really causing some fogginess over time when there's been a progression of dementia. And it's really just probably a polypharmacy effect, if nothing else, because they're on a bunch of other medications. But I've seen it so many times. Look for this if you haven't seen it. And when I tell families and staff that to expect this drop off and just to take a time out, be patient, hang in there for a couple of days, I would say 95% of the time, they don't call me and they don't panic and say we have to restart it. And then they say, you were right. They did bounce right back and they're kind of back to where they were before. So don't reflexively add it back. 2 weeks is a great goal for a washout. We talk about this with gradual dose reductions in general with psychotropics. But typically people don't have an immediate effect. So when you stop a medication, you get a call that night from the nurse that said we have to add the med back. Rarely, if ever, is that the case. So setting the expectation to wait a few weeks before we add back is really important. Next slide, please. So here's this great algorithm from deprescribing.org, which I'm sure you're all familiar with through this initiative. And I will not read this to you. It's very well done and describes exactly the way I would go about this. In that first big column, it basically elaborates, when people have a fall off of cognition, are not showing any benefit, or they're at end stage, it's clearly time to stop the medication and begin the trial. It's that middle bubble, which I think is really important. Do they fulfill one of the following? So even if they haven't had a huge drop off, thank you, Sabina, for circling that. It's really important to look at this piece right here. A lot of times people with dementia don't really like taking meds, which is another great reason to deprescribe them. So if somebody doesn't want to take a medication that's barely helpful, if at all anyway, for goodness sakes, stop the medication, okay? Refusal or inability to take the medication. This is not a medication I would put down anybody's G-tube. This is not a medication that should be continued for any reason once people don't want to take it. Certainly drug-drug interactions, like we talked about it before. Severe agitation and restlessness is a reason to stop it, not a reason to keep it going. And that's really an important take-home point. And of course, if someone's at the end of life, I don't know about you, but I plan on taking as few pills as possible when it's my turn. So please don't bring me a medication that doesn't work and that causes me to have diarrhea when I'm at the end of my life. So when people hit that stage, it's important to stop. This is one of the medications right there next to the statins that I would just take off the list no matter what. So, and I won't read the rest of this to you, but it is there for your looking, and I'm sure you've been online to see the great work from this group, and really, really support it and encourage you to look at it. Next slide, please. So this is the practical summary, and then we're going to look at the case and take some questions. The bottom line is these medications don't work great. or otherwise we wouldn't have an epidemic of dementia and people living in nursing homes with dementia. And progression of the disease is by definition a reason to stop medications, not to continue them, and certainly not to start them. If you weren't aware of it before, I hope you're very aware now of the side effects caused by cholinesterase inhibitors and recognize that it can lead to this prescribing cascade. I will just take a minute again to talk about the family situation here. Just this morning, I actually really just got off of a call like an hour ago where there's a family, a woman has severe dementia, but she's comfortable. She's not having any GI side effects. The family is completely wedded to keeping her on her 5 milligrams of Aricept. And I said, absolutely, just keep it. So in the absence of side effects, in the absence of drug interactions, and in support of this therapeutic alliance with families, it is okay to keep them on with a lot of shared decision-making. And it is not a fight I want to pick. I'd rather pick a fight about opioids or benzos or other medications that may be causing harm. This is one I'm willing to leave in the on category. So I'll stop there, Sabina, and see if there's questions. And I know we're going to talk about the case more.
Well, thank you, Dr. Watson, for this really wonderful and concise summary, and it answered a lot of my questions, but it brought up quite a few questions. Just in general, I love the practical summary. So we all know practical steps or how it informs our practice now. So thank you for that. And we wanted to bring up some questions. Arif, do you want to go through the questions that came up in the chat?
Yeah, sure. I mean, I think my favorite question is about how do you deal with anti-dementia drugs and the interactions they may or may not have with antidepressants, and how do you assess what is working and what is not working? How does that make the whole situation pretty complex? So that's a very good question. And, you know, I know that I'm pretty confused about the data, because I think the last data I've seen is that really the role of SSRIs in dementia patients has not been proven to be very effective anyway. So I would love to hear your thoughts on that, Sabina, on the whole topic.
Yeah, Sabina, you want to?
No,
sorry, I meant to say Leah. I meant to say Leah.
Okay.
Sorry about that.
I have an opinion, but you don't want to hear it.
You just thought I had the really cool red glasses on today, or not me. Yeah, so this is a great question. Again, so one of the things I do for a living is I run a lot of psych pharm meetings. And so it happens every day of my life that we're in a psych pharm meeting and someone came to the facility with moderate dementia or end-stage dementia, and they're on Aricept and Memantine and Celexa and Seroquel and a little Depakote. So how the heck do you know what's happening? The answer is you absolutely don't know. But the way to go about it is to start peeling things back, typically in the order of the most serious and detrimental. And you can determine that based on side effect profile. You can determine that in a lot of ways. Aricept would not be the first thing I would remove in this case. It would probably be the antipsychotic, and then I'd look at the different side effect profiles. But the data for the use of antidepressants for the agitation or BPSD of dementia is essentially negative. We could review that another time, and I can refer you to some papers if you're interested, but it really is all negative. In fact, they cause harm because, as we know, antidepressants are not benign. They increase the risk of falls, they increase the risk of bleeding, they increase the risk of seizures. So people often view SSRIs as being completely benign. They are absolutely not benign. And we know that even the data for the depression of dementia, which was a thing back when that we studied a lot, the data are abysmal. So we've actually done several trials. You may have heard of the DIADS trials that looked at using antidepressants for the depression of dementia, and they don't work well at all. So no better than placebo, and they actually have a higher dropout rate. Now, someone might ask me, well, don't you ever give antidepressants for people with dementia? And the answer is yes, every day. But I'm treating symptoms, and I do it in a very short-term prescribed way. So if someone is wandering and restless and doesn't like to get her bath, that is not something that an antidepressant is going to fix. If someone is crying, staying in bed all the time, making sad comments that actually match her facial expression, looks sad, seems sad, talks about sad things, even though those data show me that antidepressants don't work well for the depression of dementia, I'm willing to try that for a quarter or two to see if I can make that lady feel better, right? So it's all contextual. So the question is a perfect one. There's no easy answer, but it's really about peeling things back one at a time. And I'll just say right now, Depakote is about the most overused medication in nursing homes there could possibly be. And it's because of this substitution effect for substituting for antipsychotics, which have been under higher scrutiny and are now counted in your star ratings. So people are trying to get people off of the antipsychotics, and instead they're being put on Depakote and other agents.
Well, Dr. Watson, we're going to have you back just on a whole other session on those drugs because we realize they are really ripe for discontinuation, how to do it best. So hold on now, keep the thoughts going, but folks, we're going to Leah back to teach us about that as well. There is one question.
Sabina, can I just say one thing though? Because it is so easy to get demoralized about this, to come to a psych pharm meeting and people are on so many meds and you just want to throw your hands up, and the family wants one thing and the nurses want other things and they're on all these meds.
Yep.
Just don't give up. You know, my mantra is, you know, forward, slow is still forward. And so peel off one thing at a time. Don't give up. Just keep going, and before you know it, they'll be off of all these things and you'll have built trust. And just know that there's no absolute right way to do this. And so any effort you're making towards it at all is a huge plus for the patient.
Yeah, and if you do feel like giving up, you can see the first quote which Sabina shared from one of the physicians who's part of the DD2 program. So yeah, I mean, there's many great examples. Well, we have very interesting questions, and one of them which I'm really interested in, Leah, and we have short time, so we may need short questions answers. Rod Sanchez is asking, I'm a tad thrown back by this discussion. For resident with dementia that experiences neuropsychiatric symptoms, the alternative is using antipsychotics. I'm worried that this is where this discussion is going. Not clear to me that antipsychotics have a better side effect profile for resident that begins to have delusions and hallucinations.
So it's the perfect question and the perfect problem that you have exposed, which is that we don't have any good medications for BPSD. We just don't. That's why there's none approved for it. And they all have big black boxes around them and they don't work. So really important to get out of this sort of black and white thinking, which is that if I don't use this, then what am I going to use? The answer is let's try not to use anything, right? Which I know is easier said than done. But the CMS guidance and the regulatory guidance about medications requires that the staff document multiple non-pharmacologic interventions that have to be attempted prior to even considering any medication. And of course, that's easier said than done. I know people often live in homes where they're sharing rooms and it's a chaotic environment. And really, if we could create the perfect environment in many of these spaces, we wouldn't have these behaviors, but we can't. But the answer is absolutely not to substitute a medication for that. And I know when we get calls at night that's not an easy thing to answer to, but it really is the truth. There are no good medications. And if you want to try something one at a time to see how it works, that's fine. The only 2 times I will use antipsychotic medication for behaviors is if there is a safety issue, a safety for the patient or others in that they have unprovoked aggression, or if they truly have acute psychosis. So they're not seeing the sweet little men under the bed that are bringing candy canes. They're actually feeling like someone's coming in with a gun and it's going to kill them and they're scared to death. You absolutely can use an antipsychotic, and you should, but only in those 2 cases. Most of the time that we get called, it's about people screaming or restless or they're resisting care, and it often reflects an unmet need that can be targeted with a non-pharmacologic intervention.
Yeah, I couldn't agree more. I'm a big believer in root cause analysis of behavior.
Right.
That is where it's all at. And
right.
Yes,
yeah.
I do sit in a lot of psych meetings as well. Any other questions?
Yes, I'm going to throw a yes and no question for Leah. Mediterranean diet, yes, no, for helping with dementia.
It's not going to help with dementia, but it sure might help prevent it. So, you know, I don't know if you saw the big headlines this last week. If you adopt the Mediterranean diet, you can add 13 years to your life. I think I will take a little pause here to say, you know, good sleep and diet and exercise are the only things that we can all do to help ourselves have a better, you know, risk
And a social
profile.
life, right? And
Right,
socialization.
and social connectedness. And the other thing that if you haven't read about it is super exciting in science right now is the gut-brain connection. And it may sound simple just to eat your fruits and veggies and exercise, because we've all been told that forever, but the data are absolutely astounding at what changing your microbiome and your gut does to create your brain health and to help improve your immunity and decrease your risk for dementia and for cancer. I cannot believe we don't talk about it more than we do, because we're way too worried about finding a cure than we are about prevention. So eating fruits and vegetables is not going to help with dementia. In fact, I say give them all the ice cream they want. But for those of us that are trying to stave off future dementia, absolutely, lifestyle factors are the only thing we can do.
Guys, can I read Sabina? Sorry to interrupt. Just my favorite comment has just arrived, and I think that really points to a lot of problems. Penny Logan says, not enough time put into understanding the why the behavior is happening. Medication is thrown into the play way too soon. Education for the caregivers. Wow. I think that's just a very, very important comment. Sorry, Sabina, I know you were going to.
Oh, couldn't have said it better to the point. So yeah, thank you, Penny Logan, for that comment. So we have a couple minutes left, and we're going to do a really quickie on this particular, and I think we already covered a lot of topics on that pertain to Mrs. Smith, but just to say that she's been on donepezil for 5 years, prescribed by her PCP, and she is now multiple months after her admission, and her function is actually not back to baseline, and in fact, she is now developing dependence in eating, which she didn't have before. She does enjoy her grandchildren, though, although she doesn't necessarily remember their names. What would you recommend? I think that's almost a rhetorical question at this point.
Yeah, so clearly she's having side effects of diarrhea, of diarrhea and GI effects. And we don't want to create this prescribing cascade. And she's obviously had a progression of her disease. So we want to get her on as few medications as possible. And this will be top of my list to recommend decreasing and stopping.
And now we deal with the family. She has 2 very involved daughters.
And Sabina, that was one of the questions also. So I'm glad you're asking the family question.
Yeah.
Yeah, she has, you know, and she is African American. So there is per se potentially a distrust in the healthcare system, well founded, especially at her age. They don't want to give up on her, and she's been told that she needed to be on this medication. How would you approach this situation? You've given us
this is so tough, and again, there's no right or easy answer. It's really about creating a trusting relationship with the family to really validate to them that you recognize that this medication symbolizes their love for their mom, but that because of how the research has gone and what her symptoms are now, that the diarrhea and her inability to take care of herself really are showing us that her disease has gone forward, and the kindest and most compassionate thing to do for her is to take away the things that are not helping her, and especially if they're causing her harm, and that it has absolutely nothing to do with giving up on her or how much you care about her. And then let's have a conversation about ways that we can care for her now. What can we do to bring the grandchildren in more often? Should we revisit the goals of care? Is she uncomfortable in some other ways? Do we need to talk about stopping other medications, creating new rituals, doing new things? It's really about relationships and about validation. And were she not having side effects of diarrhea, I may leave the medication. And there's some families, I have families that tell me over my dead body, I will sue you, I will sue the facility, and I will take you to jail if you stop my mom's Aricept. And I'm like, I get it, you know.
And you can go to jail too if you are not doing your job, and you can get sued too if you not doing your job. And if you are giving the family to make a decision on pills, you're not doing your job. also.
Well,
Exactly. And then remember the mantra that my friend Greg Gomes taught me a while back, which really holds true, is you need families' permission to start medications, but you do not need them to stop. Just remember that. It's your name, it's your license. And if this patient was having diarrhea all the time, or let's say having horrible insomnia or some cardiac issues, it wouldn't matter what the daughter said. You would do your best to have an alliance with her, but you would not be practicing good, safe standard of care medicine if you continued the medication.
Very well said.
On the other hand, your practical approach, if there's nothing wrong with the patient otherwise, it also marks you as a very empathetic physician who was also really treating the family in a
Right.
way. And I think I would want you as my father's physician for sure.
Yeah.
So
Great.
I
I do want to, Sabina, as the guardian of the chat, I do want to insert one question because somebody really wants to ask this question, so I cannot disappoint them. So Nurat has asked twice now, do you believe the key in treating dementia, Alzheimer's disease is to treat cognitive deficiencies early or not at all? Do the current studies show benefit only in the early stages in the slowing the disease process? Question.
Well, Nurat, it's a great question, and one that is quite at the top of everybody's minds in the field right now. And I don't pretend to have all the scientific answers, but it's pretty clear to me and to the people that I trust and respect in the field that we will never fix Alzheimer's once it's started. Okay. And that's why we're looking at biomarker data and why people are so eager to get in early before people have symptoms. So I don't think that the cholinesterase inhibitors really ever worked. They haven't made a huge difference in any important outcomes. And I think once the horse is out of the barn, we're not going to put it back in the barn. So the real breakthroughs are going to come in prevention and in early identification of biomarker disease, which is, I think, where they were going with Aduhelm, of course, but they can't do the trials in people that are pre-symptomatic for a lot of other reasons. But if someone has a bunch of amyloid in their brain and they're not symptomatic, it does make sense to think that if we reduce the amyloid, we might prevent them from having the disease, not bearing out that way. But it'll be something along that line as to how we make progress in this field. What I really want to leave you with is that 6 million or more people in this country have dementia. 10,000 people are turning 65 every day. We have a crisis of care for dementia that is really eclipsing any consideration of cure. I want the people to keep working on the cure, but we really need to think about caring for people with dementia and not about reversing it or fixing it or having a medication that's going to save us from it.
Wow.
Wow, what a session today. We really want to thank you. You know, you've just been a wonderful, knowledgeable, empathetic panelist, and it's been an absolute privilege to have you on. And we're going to get you back when we talk more about some other psychiatric medication. And many of our participants have really enjoyed this. Just
wonderful.
To before we log off here, I just wanted to put your attention once again to the Spearhead group. This is your opportunity to recognize your high-performing center and get drawn into the D2D discussion. And a little bit of advertisement. Our D2D initiative is going to be presented, and we'll talk more about D2D at the conference in Baltimore on Thursday, March 10th, 4 to 5:30 p.m. Please join us there and feel free to chime in there on what your experience has been as well. Our next D2D progress update will be on March 17th in exactly a month. And then the next webinar, April 21st. Again, thank you, everyone. Thank you to the AMDA staff. Thank you to the audience that has been so interactive.
And Sabina, I do have to say that there's many people who have said that they just loved the session. So just great feedback.
Yes, it's coming. I hope you felt the love, Dr. Watson.
I did. I always feel the love from AMDA.
Okay.
You guys are my people.
All right. All right. We hope to see everyone in Baltimore or online. Thank you very much. Bye-bye.
Thank you, guys.
Bye.
Bye.